The brachial plexus is formed by the roots of 5 and 6 forming the upper trunk, the 7 forming the middle trunk, the 8 and 1 forming the lower trunk. They divide into anterior and posterior divisions. The anterior divisions of the middle and the upper trunk form the lateral cord. The posterior divisions of all trunk form the posterior cord, and the anterior division of the lower trunk forms the medial cord. They are called the lateral, posterior and medial cord because that's their relation to the brachial artery. The lateral cord continues into the musculocutaneous nerve, the medial cord into the ulnar nerve, and the posterior cord into the radial nerve. The branches of the roots are 3, 4, 5 phrenic, 5 nerve to rhomboids or dorsal scapular, and 5, 6, 7 nerve to serratus. They supply all the scalene, medius, anterior and posterior and give rami communicants to the sympathetic trunk. Now this is very important and you must know because this produces Horner syndrome, and this Horner syndrome makes you recognize a correct injection into the stellate ganglion which you have to give in vascular insufficiency of the upper limb. So the Horner syndrome will deal with somewhere else, but then the trunk, the suprascapular and nerve to subclavius. The nerve to subclavius gives an accessory phrenic nerve, which winds round and hooks the subclavian vein and meets the phrenic. Now this causes spontaneous axillary vein thrombosis because of stasis. Then the branches from the cord, so lateral and medial cord, lateral pectoral from the lateral cord, medial pectoral from the medial cord, and medial cutaneous nerve of arm and forearm from the medial cord itself. Then from the posterior cord, besides the radial, median, ulnar and musculocutaneous, besides these, the posterior cord gives rise to upper, lower subscapular, nerve to latissimus dorsi or thoracodorsal, and axillary nerve. The axillary nerve passes through the quadrangular space, supplies the teres minor, which has a pseudoganglion, supplies the deltoid, pierces the deltoid, and supplies the regiment batch area under the acromion process. Then this is the ERBS point. 5, 6 anterior posterior division, suprascapular and nerve to subclavius. This ERBS point is pulled in normal or breech delivery. The forceps normal, otherwise breech. It can lead to neurapraxia where the exofibrils are intact, or axonatomesis where the axons are not intact but the nerve sheath is. The third is neurotomesis where the sheath and the exofibrils both are destroyed. Now, this in axonatomesis, one segment proximal, there is intact exofibrils, and all the rest there is only nerve sheath. Now these axons will grow at 1 millimeter per day, taking 3 days to cross the joint. And as they cross the joint, they will go and meet the muscle. But if they don't do it, in 9 months' time, then the muscle gates will close and the muscle will never recover, and this is called as residual paralysis. Now what is the position? The abductor of the policeman tip taking position. Make it and see that the abduction of the shoulder is lost, the flexion of the elbow is lost, the supination of the radioulnar joint is lost, and dorsiflexion of the wrist is lost. Now, if you want to prevent contracture in the situation, you put the patient in policeman, put the patient's arm in policeman's stock pull. Immediately it's the reverse of all this. Then you monitor recovery and ensure muscle tone. You monitor recovery clinically by Tennel sign and motor march. That means deltoid will recover first and then the biceps and the brachialis. Then by electrodiagnostics, you can monitor by galvanism converting to Faradism. That means ability to be stimulated by more than 3 millisecond stimuli only to ability to be stimulated by less than 3 millisecond stimuli, the SD curve. Then gradually the power comes back and you can do active assisted exercises, then active exercises, then active resisted exercises. So now in the nerve conduction velocity, you know that if the exofibrils are intact, there will be a biphasic potential. Now across the lesion, there will be, the distal one will be lost, so there will be a monophasic potential. Distal to it, there will be no conduction if there is Wallerian degeneration, but there will be a biphasic potential if there is neuropraxia, and all this will occur after 21 days. Because till 21 days, you will not be able to distinguish neuropraxia and Wallerian degeneration. Wallerian degeneration takes effect at 3 weeks. So during the recovery phase, you have maintained the muscle tone and you have monitored nerve recovery. Now if 9 months have passed and the nerve is not recovered, then you replace deltoid by trapezius, you replace biceps by pectoralis minor. You know biceps originates from the coracoid process, short head, and pectoralis minor is also there. So you simply detach it from the costal surface and put it back into biceps. So simple. And that restores both supination and flexion. The other thing to do is that you take a trunk, a part from the ulnar or median nerve, and this is the musculocutaneous nerve where it is entering the muscle. So you divide it from here and you attach this exofibrils just at the myoneural insertion. So this is intact exofibrils, they will immediately innervate the biceps and brachialis. So this is called as Oberlin procedure. Right? Then dorsiflexion of the wrist, the extensor of the wrist by pronated teres. When you pronate the wrist, there is dorsiflexion, pronation, the forearm, there is dorsiflexion of the wrist. So they act in the same phase. They are called as synphasic. Then abductor of the thumb by palmaris longus and extension of the MP joint by flexor carpi ulnaris. The flexor carpi ulnaris and palmaris longus are acting in the open phase of grasp. And so is thumb abduction and MP extension. So this transfer is a synphasic transfer. So we have covered the ERBS palsy and the structure of the brachial plexus.